Right. I would ask participants to keep themselves on mute unless you want to contribute to the conversation, in which case, obviously, unmute and take part in the conversation. We do encourage questions. Let me introduce you to our teacher today. So Mr. Mohammed is our special teacher. He specialised in retinal disease at Moorfields after doing his training in Sheffield. He was awarded the prestigious Wellcome Trust Fellowship for his research into, let me get this right, molecular and genetic basis of inherited eye disease.
Something like that's enough to put most people to sleep, but
something like that. Obviously, he's one of our consultants at St Thomas's Hospital, and where he's involved in teaching, training, seeing patients, of course. He oversees the clinical audits. He's also an examiner for the Royal College of Ophthalmologists, and he has academic ties with University Eye in Dar es Salaam. Is that right?
Yeah, I've just spent the last week there, so so we've just done a bunch of teaching, and actually I gave a very similar talk to this, so to a bunch of ophthalmologists. No, that was quite well received. So let's see how it goes tonight.
So we welcome feedback as well from today. Okay,
yeah.
So I'm going to hand over to Mr. Mohammed. Thank you very much.
Yeah, so because we're going to do like a year's worth of stuff, please do feedback, and we'll change and adapt things as we go along, because everyone's got different needs. So let's here we go. So the idea of today, really, we'll just go over very basics of how to interpret an OCT scan. So I'll just say right at the bottom, it's really about confidence with describing and interpreting an OCT scan. And this is not a talk about disease, because I'm going to show OCTs of some weird and wonderful stuff. But feel free to interrupt at any stage if you need clarification or have any questions about anything. So we'll go through what a normal OCT scan entails, and just some sort of system to approach as a way of approaching how to interpret the findings. So whenever my new trainees come, I always show them a picture like this and say, where is the macula? And it is amazing how varied the answers can be. So there are two definitions, clinical and histological. So it's called a macula lutea, where luteal pigments are. But essentially, it's that sort of area, two disc areas in radius. So histologically, it's where the ganglion cell layer is more than 2 cell layers thick. And that is important because we can see that on the OCT scan, and we'll point that out as we go along. Moving on to the sort of basics of anatomy, we'll define where the fovea is. So it's about the same size as the disc, right in the middle. And then the fovea's got structure within, and we can see those changes within, not only on an OCTA, things like the foveolar vascular zone, but the foveola as well. So the foveola is where there's cones only. So we can see that, and there's the cones only and no ganglion cell layer. So there's an absence of the plexiform layer. But again, rather than going through these terms now, we'll look at them all on the scan. And then other things, of course, there is the parafovea and perifovea, and you may think they're very archaic descriptions, but of course every OCT scan we see has the ETDRS circle, and the ETDRS circle isn't exactly the fovea because it's 1 millimeter rather than 1.5 millimeters, but it is looking at the center of the macula. So the first ring around is the parafovea, and the perifovea is around, which is pretty much the whole macula. And another question I ask my trainees all the time is, how many degrees of vision does the macula give you? So it is about 20 degrees or so. And an AMSA grid, if it's held correctly, is 20 squares by 20 squares, and each one of those squares should be about 1 degree of vision. So that tells us approximately what the macula, which area it subserves. And then other definitions is the near periphery is between that circle to the vascular arcades. So it's not the whole area within the vascular arcades, which is the macula. And then just going a little further out, the mid periphery is between the arcades to the equator. How do we know where the equator is? Well, it's where the vortex veins are. So here's an albino patient, and the vortex ampulla is very obviously delineated here. So the back end of the vortex veins is pretty much where the equator is, and anything beyond that, as we said here, is the far periphery. just so we've got the definitions all correct. And you can sort of tell another way of telling where the equator is, where the short posterior ciliary nerves. See, they're not always visible, and depends on whether the patient's pigmented or not. But you can certainly see the long ciliary nerves coming in. So we all learned this in medical school or optom school, whatever, and it was learned, memorized, and then forgotten. But of course, the importance has become greater and greater with our increased reliance on OCT scans. So once while you love the 13 layers or 16 layers or however many layers you think there may be, and it has this ridiculous complexity, it isn't that complex really, and there is this absolute point-to-point comparison. So, you know, the ILM, the inner limiting membrane, we can see on the OCT scan the plexiform layers where the cellular layers interconnect with one another with synapses. We can see the nucleated layers. We can see. So we'll just go through these layers one by one and the importance of these, particularly as scanners get better, diseases get more and more defined on OCT, because pretty much everyone that walks through our clinic now gets an OCT scan. They get their vision, they dilate, they get an OCT scan, and then they come and see the doctor. That's how the MR clinic works, probably in most places, in actual fact. So despite that complexity, in actual fact, it isn't that complex because there's basically 3 orders of cells: the photoreceptors, which capture light, and every cell's got a nucleus and synaptic connections. The bipolars, where the primary visual processing happens, the ganglion cell layer. So we've got to remember there's like 120 million photoreceptors in an eye, but there's only 1.2 million ganglion cells. So there's a huge convergence of information, and that convergence of information is that primary visual processing which happens. And then there's a few other layers. So that complex thing can be very much broken down to a very simple structure. So basically, the pigment epithelium nourishes the photoreceptors. The whole visual cycle and the chemistry of vision happens in this complex. And there is that subretinal space between. The photoreceptors connect to the bipolars, where there's also horizontal and amacrine cells, and it's those synaptic connections where that primary visual processing happens. That's the outer plexiform layer. And then there's the ganglion cell layer, which is what relays back all the way into the thalamus, the lateral geniculate nucleus. So they're very, very long cells, and they take that 90-degree bend at the optic nerve head. So very, very important structure for all sorts of things like glaucoma and optic neuropathies and what have you. So basically 3 layers of cells. So we do see those 3 nucleated layers very easily, and 2 synaptic connections. And then there's the outer retinal complex. So again, we're going to look at this in a bit more detail. Now, again, this was the sort of thing we all learned in first year of when we started studying eyes. So is there any point in knowing the stuff? Well, absolutely there is, because, well, as Bhavina said, I do a lot of inherited eye disease. So certain diseases will manifest with changes in the outer segment. So we can see that layer on the OCT scan, which we'll demonstrate, and even things like the mitochondrial layer. All the current modern classifications for things like geographic atrophy, which we'll come to later on during the year, all depend on whether you can see the exact structures of where the outer limiting membrane is, where the mitochondria are. And I think we've got a case for discussion later where we'll look at some of these structures. So again, that distribution is huge. It's really cones only in the foveal center, but the cones are all the way out. They do go out to the periphery. So if you do an ERG on someone and they've got profound macular loss, they'll still have a normal cone ERG because you've still got lots of cones going out to the periphery. So again, it's a misconception which we need to break. And then obviously rods are distributed all the way out, and that gives you nighttime and peripheral vision primarily, but the cones are out there. And then we've already mentioned that the primary visual processing happens at the eye, at the ganglion cell, at the bipolar layer, and not in the primary visual cortex, which is where traditionally and conventionally we've believed primary visual processing. And the eye is the retina is just that externalized bit of the brain which has been modified and adapted to collect light. So we're lucky in medical retinal disease. So things like MRI scanners give us a certain degree of detail, but there's an order of magnitude greater in terms of what we can see on an OCT scan. And things like the external limiting membrane is thought to be 10 micrometers, so 1/100th of a millimeter. So it is phenomenal detail. And then in the clinic, we'll use so-called multimodal imaging, often an OCT plus or minus an angiogram or an OCT or ultrasound, and getting little bits of the jigsaw just to try and patch it all together. Autofluorescence should be up here because it's another modality we use very commonly, particularly in inherited diseases and things like macular degeneration. So in terms of OCT interpretation, if anyone wants the absolute landmark paper, well, you can look on the on the recording later, but this proposed nomenclature was a few years back now in 2014, so it's a decade old now, but it's really sort of crystallized as to what layer we should be calling what. So when we look at an OCT scan, really the first thing we're going to do is just assess the scan quality, because we're doing that scan for a reason. And that reason is to try and get as much information from the scan as you can. So the only difference between these two scans is this patient had dry eye changes, so we put a couple of lubricating drops. You get a similar sort of effect if someone's got cataract. If you dilate the pupil, sometimes you'll get through the cataract a lot easier, so you'll get a bit more information. And sometimes just the correct focusing on the OCT scan, depending on which machine. So again, you're doing a picture, try and get as much information as you can out of it by just being patient or repeating the scan. And rule number 2 is if any of you are still looking at your scans in color, it's a false color palette, so it's a very limited scale, whereas looking at exactly the same image in black and white, you can see how you just get so much more information and ultrastructure. And then line scans. So again, these are still crude screening pictures when we do that block scan across the macula. You can do line scans, so you can see the difference between the two here. If you just get an average line scan, again, there's a huge jump up in the amount of information you can extract from a scan, and then not to forget that you can do an EDI. So if anyone remembers those cat experiments from the 1960s, Hubel and Wiesel, we have feature detector cells in the human retina and human vision. So we're particularly tuned in to detecting horizontal and vertical lines. So what could be more perfect than looking at an OCT scan? Because it changes once you know what is normal. If any deviation from that expectation happens, then there's got to be some sort of pathological process going on to explain that variation. So this is an EDI scan, so you can see the difference in the choroid. So if you look at this outer area there, let me just put the laser pointer on. Yeah, this outer detail. So more and more. So I do a lot of CSR work and treatments with PDT. So it's the first thing we look at in a CSR case is how thick is the choroid and how anomalous are the blood vessels. So there's Haller's layer, Sattler's layer, chorocapillaris, and Haller's layer is usually almost uniformly abnormal in CSR patients. So these things are important. So can you see? So I've got all that. Yeah, can you see that here? So we've just got this. We'll just go through this approach. So how I normally go through this with my trainees is just go 1, 1, 2, 3, 4, 5. And these are all the layers we're looking at. So number 1 is just look at the foveal contour. We'll look at examples of all of these things just to make sure it's smooth and regular and follows that little smooth depression. And any deviation from that, whether it's something putting the retina up or something constricting the retina down, usually should be explained by some sort of pathological process. So that's 1. The other 1 is, oh, sorry, I forgot to mention this. So we know, how do you know you're exactly at the foveal center? Well, there's no outer plexiform layer at the foveola. So the fovea is about 1.5 millimeters. So it's from the shoulders here to here, and this whole clivus is so the fovea is that sort of layer. The foveola is that little bit in the middle, and then the umbo is where you've got tightened and widened cones, so it looks like the ellipsoid line just jumps up there. So the next number one is the nerve fiber layer, and it's amazing how often this structure is overlooked. So that's the little white wedge which points in then to the optic nerve and then forms the optic nerve. It's the axons of the ganglion cells. So there's 1.2 million cells in that, really, really key. And in patients who've got glaucoma or optic neuropathies, that little wedge of tissue thins out. So that's 1 and 1. Now we're going to move to 2. So 2 is the plexiform layers. So again, they just run smoothly all the way across. And they're the synaptic connections. So the plexiform layers are bright. Okay, so they're whiter in their signal intensity. And then 3 is so we've got the outer plexiform and inner plexiform. So that's the connections between the photoreceptors and the bipolars, and then the bipolars to the ganglion cell layer. And then 3 is the 3 nucleated layers of the retina. So of course, the key element is the photoreceptors. So the photoreceptor nuclei are that dark band. If you look very carefully, there is actually an additional extra line. We'll point that out in a second. So the widest and broadest is the photoreceptors. The second broadest, deepest is the bipolar cell, sorry, the ganglion cell layer, and then the bipolar is the sandwich in between. So you've got 1, 2, 3 nucleated layer. And then it's sort of important to look at the, I didn't mention this yet. So if you look very carefully in the outer nuclear layer, it's a wide zone, but you can see this extra little line just there, and that's Henle's layer, if you remember that from your anatomy books. So Henle's layer is where the axons are slightly displaced to maximize the photoreceptor concentration. So you can see that extra line in the outer nuclear layer if you've got an average scan. So outer retinal bands, so when we're going on this 1, 2, 3, 4 method, is you see the external limiting membrane, really important. It's where the Muller cells end. Then the second line is the ellipsoid line. So that's the mitochondria within the cell. That's a powerhouse of the cell. And the photoreceptors are allegedly the most metabolically active tissue in your body. So there's a high density and more mitochondria per unit mass than anywhere else. This third line here, so it's 3 bright and 1 faint-ish line. The third line is the interdigitation, which is where the cone outer segment tips and rod tips then embed into the interphotoreceptor matrix and the inner aspect of the pigment epithelium. And then the pigment epithelium is the third bright line and the fourth of that complex, which are called the highly reflectile outer retinal bands. And then 5 is the 5 layers of the choroid. So you'd only really see Brooks membrane, which is the inner aspect, if there's a detachment of the pigment epithelium. And then you've got, and then the outer boundary is lamina fusca. And again, this is becoming more and more important. I mean, traditionally, it's only if someone's had a suprachoroidal hemorrhage, but there's a whole tranche of new drugs being developed, which are going to be delivered in the suprachoroidal space. So special needles being delivered, lots of genetic-based therapies, a lot of steroid therapies are all being designed to be given into that suprachoroidal space. So it's going to be an important therapeutic space. And then the choroidal vessels, there's large bore, medium bore, and the chorocapillaris. And certain conditions show abnormalities. So there's, again, a whole new lexicon of diseases which are defined as part of the pachychoroid spectrum. And the pachychoroid is defined if the choroidal depth is more than 400 micrometers. Normally, it's about the same thickness as a retina, somewhere about 320 to 350 in terms of the micrometers and depth. So certain diseases like age-related macular degeneration show a thinning. Myopia shows a thinning. Certain diseases, thickening, and of course, there's all sorts of inflammatory diseases that can happen there. So we're visualizing the choroid and paying more and more attention to the choroid day to day. So, and just from that nomenclature paper, which I mentioned earlier on, this is the sort of standard nomenclature, accepted terminology where we want to define things. And there's other things that can be defined, like the myoid, which is the Golgi apparatus, where all the protein processing happens. So we can see amazing, amazing detail. And there is neuro-OCT technology. Some of you may have swept source machines in your practice, which is wider and deeper in its penetration. So we can see scleral structure becoming more and more important for things like myopia research, emissary vessels, anterior orbital fat, and we see detail in the vitreous as well. So that's the premacular bursa and space of Martigiani. And then for wider pathology, like a posterior staphyloma or a dome-shaped maculopathy like this, you can just appreciate the variation in anatomy that goes on, and then all sorts of clever 3D reconstructions of the anterior segments. And adaptive optics, very much a research tool. We do gene therapy, or have been involved in a gene therapy trial, so these things are important for things like that, where photoreceptor structure can be identified. So that's the rods and that's the cones. But the downside is it's time-consuming and very, very narrow field of view. And then things like the OCTA, which is becoming more and more part of our day-to-day practice. And anyone who's got choroidal neovascularization, diabetic retinopathy with potential neovascularization, then we do a lot of sickle work, as many of you will do. And sickle causes widespread retinal vascular occlusions. And then the newer machines are going further and further out. Of course, there is a difference between conventional angiography and this, because it tells us structural change. It doesn't tell us functional change. So we can't really see where leakage happens on an OCTA. It just tells us about the structure of the blood vessels. But often it's enough to work out for the key diseases as to where the pathology is and what information you want to extract out of that retina. And this is a photoshopped image. Some of you may have seen this, but it's a sort of beautiful example of a montage where the whole eye can be pretty much examined in great detail with scanners now. So moving on, we've got this approach of 1, 1, 2, 3, 4, 5. We don't do that on every scan. Really, on every picture, there's only 2 questions you really need to ask. Firstly, is there a normal shape, or is there an abnormality of shape? And then and is there a normal structure of the retinal bands? And we've already said it's very easy for the human eye to detect these parallel lines, and any deviation from that parallel has got to be explained. How do we explain abnormalities? Well, if it's an abnormality of shape, is it full or local? And we'll give examples of all these. Or is it an abnormality of structure? In which case, decide where the abnormality of structure is. Is it pre-retinal, epiretinal on the surface, intraretinal, subretinal, sub-RPE? Because we can see all these tissue layers. And then you've got to decide, is it abnormal because there's extra tissue, like leakage or exudate or hemorrhage, or is there missing tissue because of atrophy? And the various reflectivity characteristics will tell us, is it fluid or solid or fat, and various things. So all these different approaches will end up sort of telling us exactly what's going on. So again, we don't need to dwell on this too much, but you all know that certain tissues have a high reflectivity, like the vitreoretinal interface and exudates. I'll give you examples of all these. Moderately high is things like the nerve fiber layer, which appears quite bright. And then going to the other end is things like vitreous, which is black. Vitreous, we know, is 98% water, 1% collagen and matrix proteins and glycosaminous glycans and what have you, which give it that gel structure, which then degenerates through age. So those things look black as opposed to some things which look very white. So here's some examples. There's an epiretinal membrane, which looks very white. Exudates here looks very white. Again, we'll look at these things in a bit more detail. Moderately high signal and things like blood. And the nerve fiber layer, so not quite as bright white as the things seen here. They get slightly grayer. And then going to the other end, things like the retina, defined as moderately intense, and the choroidal detail. Again, if you want to see the choroid, you've got to switch your machine into an EDI, enhanced depth imaging mode, to visualize those vessels. And if you haven't got that as a setting on your machine, you can sometimes just push the joystick forward, it flips the image, and then you can see the choroidal detail in that way. It just depends on the sophistication of the machine you have. But I think most modern machines have an EDI setting. And then it sort of goes on. If you've got vitreous debris, it's not quite as bright as the other structures, and then going on to fluid, which then looks black, and shadowing. So if you have pigmentation, you have shadowing behind, because these images are made up from the reflectance of light. So again, we just use those characteristics to try and work out what on earth is going on. And then there are proposals, but it's not cast in iron as to how we describe these changes. So if there's an irregular pigment epithelium, it's that sort of zigzagging or corrugation. Things like fragmentation. Some of those lines get broken in multiple places, so we'd call that fragmentation. If there's a pigment epithelial detachment, we'd call it, if there's an interruption, we'd call it a rip. Other tissues which should be plastered across the back of the eye, we'd call it an interruption, etc., etc. You can sort of take it or leave it, but it's good to have a sort of standard set of language which we use to apply to these things: elevation, depression, thinning, thickening, etc. So here's an example. We've got that image in our mind as to what a standard OCT image should look like. Is everyone following me so far, or is there any questions? Okay,
There's no questions in the chat as of yet.
Okay. So the first, we could do two things. We could just dive in and say, well, that's a very abnormal scan. But we said there's two questions you ask. Is it an abnormality of shape? And yes, there is, because it's not going straight across. So, most of us will recognize that's a very myopic eye with a myopic staphyloma. And then the next question is it general or localized? Well, it's sort of general because the whole thing is down on a slope. And then we look at the banded structure. So we can do that 1, 2, 3, 4, one by one. So this is a horizontal scan going through the foveal center, which we can see because there's no outer plexiform layer. So the first question is there a smooth foveal profile? Well, again, difficult to judge because there's something else going on. Can we see the wedge of the nerve fiber layer? Well, we can't, but in this case, it's difficult to interpret because there is a staphyloma, so it then goes into the depths of that staphyloma. Then in this sort of situation, we just look to see, is the banded structure okay? And again, because the way these images are made, it's on the reflectance of light. When you've got something very oblique, it's then very difficult to say whether the structure's there. So all we can say is this is a posterior staphyloma as part of pathological myopia. And some of the structure looks very warped, but we know in myopia it's very difficult to interpret the outer retinal bands. So in that situation, what we do is a vertical scan, because all you're doing is changing the orientation. It's like the ridge of a mountain. If you're going in one plane, it looks flat, but if you're going the other way, it's very up and down. So if you do a vertical scan in the same eye, you get much more detail on the structure, and you can see the foveal profile is normal. Now, of course, here the nerve fiber layer is running up and down, so we'll see it almost in continuity across. And then if we look at the banded architecture, the plexiform layers are there, the nucleated layers are all there. And as I've already said, it's quite difficult to interpret in a myopic eye the outer retinal bands, but they look largely intact. But to go down on the fine nitty-gritty of it, actually the interdigitation, so we can see the external limiting membrane, the ellipsoid line, the interdigitation is missing, but that's probably because of the general warpage of the eye rather than any disease process as such. So again, applying that same approach, one is the foveal dip there. Well, no, it's not, because the whole thing's being everted. This is a vertical scan, so we've got a local deformation of profile. So the retina goes down and then up and then down and up. And if we look at the banded structure, actually most of those bands are in continuity. So the two plexiform layers are identifiable. The nucleated layers are largely identifiable, but the outer retinal bands get very disrupted in this area. And why they're disrupted? Because there's a great big black deposit there. As you know, that's generally fluid if it's a low signal intensity. Again, we're not talking about the conditions as such, it's just identifying the changes. This is something called dome-shaped maculopathy, which happens in patients. It's a masquerade for CSR. So patients with myopia tend not to get CSR, central serous chorioretinopathy, but myopes can accumulate fluid which resembles superficially CSR just due to the anatomy. It's thought to be relating to some sort of outflow problems of the venous drainage of the choroid. We can discuss these things on later on in the year. So again, that same approach. One, foveal dip. Well, it's very abnormal. Nerve fiber layer intact. The obvious abnormality is a very localized deformity of the banded architecture. But if we look at the structure of the retina, actually most of it is in continuity, except here. So this is something called a focal choroidal excavation, which is part of the pachychoroid spectrum. You can see that choroid is actually quite deep. That band there, it tells us what 200 micrometers is. So approximately it's twice that. So it's going to be a thickened choroid. There's probably some sort of localized choroidal infarct, and the retina is just dropped into that void. So that's a focal choroidal excavation. But the rest of the structure of the retina is intact. It looks widened here just because of some of the inherent elasticity of the retina. So just going through, so we're going to go by layer. Now we've deliberately defocused this image so you can visualize the vitreous. So there is structure in the vitreous. There's things like Cloquet's canal and the premacular bursa, which is thought to reduce the impact and protect the macula. And then the space in front of the optic disc, the space of Martigiani. Again, a very important thing when PVDs are developing, and we think that probably is related to neovascularization of the disc as well. So if we look at this picture, firstly, we're going to ask, is that the foveal center? Well, no, it's not, because we can see the banded structure going all the way through, but it is at the fovea because you see that undulation. Now, other things we can detect is there's a partial posterior vitreous separation. There's an early partial detachment, which is just part of the syneretic and aging process of the eye. And then the remainder of the structure looks largely intact. 3 banded nucleated layers, the 2 ganglion cell layers are intact. If we look at the 3 bright bands and the single one, actually largely on continuity. Possible some fragmentation here, but it all depends on what symptoms the patient's got as to whether we take that as pathological or not. And then we can look at the choroid, so we see some undulation in the choroidal thickness and some variation. Now, part of that is normal, but sometimes it can be pathological. So take a moment, just have a look at this yourself. Try and use that approach. So I'll give you sort of 10 seconds to think about that. So if you're looking at it and follow that approach, one, we said look at the foveal dip. Now I'll tell you this is at the foveal center, and we said if you're right at the center of the foveola, there should be no outer plexiform or any ganglion cell layer. So that dip and foveal clivus is abnormal. Going to the other things, that wedge is there, the ganglion cell layers are in continuity, the nucleated layers are in continuity, the outer neuronal bands, the choroidal structure all look good. So what on earth looks like this? Well, that is foveal hyperplasia. But there's many reasons why fovea can be abnormal. And sometimes we can tell very specific diseases just by looking at the contour of the fovea. So foveal hyperplasia we'll see in patients with albinism. We'll see them in association with some anterior segment dysgenesis. This is all very warped towards my genetic eye disease interest. And then we'll see it in patients with things like familial exudative vitreoretinopathy and also in ROP. So there's a whole plethora of conditions which can give abnormalities in the fovea, and even in idiopathic nystagmus, and often correlates to some sort of mild reduction in vision, depending on the severity of the hypoplasia. So we said we can identify lots of changes in the foveal structure. So again, we don't need to dwell too much on this to say that the foveal clivus is abnormal. There's other things going on there as well. So there is a partial vitreous separation. The ganglion cell, the nerve fiber layer is intact, so we know the optic nerve is largely healthy. The banded structure runs smoothly across, so you have got that dark light, dark, and the outer retinal structure is intact. The choroid looks intact, but overall that retina looks abnormal. So again, it's a particular sort of genetic variant. And if you look on this infrared reflectance, you can see there's some sort of abnormal reflex. And it's just this jagged structure and this very bright white reflectance, which isn't an epiretinal membrane in this case, is very, very pathognomonic of another genetic entity called Alport syndrome, which some of you may know from anterior lenticonus. But the retinal phenotype is the most important change. So, you know, just from a single slice on the OCT, we can tell exactly what gene mutation this patient has, a COL4A mutation, and collagen type 4 is highly represented in the inner limiting membrane, that inner structure. So we immediately know what genetic problem this patient has just by a single slice on the OCT scan. It's not
Mr.
about,
Bennett, can I interrupt for a second?
of
There's
course.
a question in the chat about potentially, is there a break in the RPE? I'm not sure if it was for this picture or the one before.
Let's have a look. So I'll go back 3 or 4 scans. Well, that RPE again is very warped. So whenever you have a local deformation, it then becomes difficult to interpret whether something's completely intact or not. But you have got some transmission. So there is going to be some irregularity, and just from that infrared reflection, so it's very mottled. So yeah, there'll be some disruption and granularity of the pigment epithelium on that one. That RPE, the outer band, is pretty much intact all the way through.
Lovely.
That one is intact, and the triple band is really very well delineated. And that's one
I think
we're
that was the picture that was the question mark.
this one.
Yes, and I think it's just north of where you're pointing.
That thing there.
There, yeah.
So that's the outer nuclear layer. So we know there is a malformed fovea. So these little structures, so again, if we're looking at the lines, that's the ellipsoid line, the bright one. That's the interdigitation, which is the outer segment. That's the pigment epithelium. So the key elements of the outer retina is intact. There is a disruption there, but it's an abnormal signal. Now, again, this little band here, without getting too complex, can show all sorts of irregularities. There is a term for it, it's called the photoreceptor nuclear axonal complex, and it can be dark, it can be bright, it can be columnar, it can be dentate, it can be jagged. There's all sorts of variations recognized, but this is more an orientation artifact. Now, there may be structural changes here, but we know the patient's foveola is malformed, so we'll take that as part of the global appearance.
Amazing. Thank you.
Okay. So in this one, again, this sort of sharp irregularity is telltale for Alport syndrome. And the only other thing that looks like that is sickle. So most of you working in Southeast London will probably have come across sickle patients because it is worldwide the commonest genetic disease. And we've got something like 3,000 sickle patients on our books at St. Thomas's. So all of you, I'm sure, will have changed. But the difference is the foveal contour is still smooth rather than jagged. And there's no bright white line on the inner limiting membrane. So again, when we apply that same 1, 2, 3, 4 approach, foveal contour intact, ganglion cell layer intact, nerve fiber layer intact, plexiform both in continuity, all nasally, but it all gets very disrupted. When we look at the structure, actually the outer retina is intact. It's the inner retina which has been compromised. That's a very classic change of sickle, because sickle causes vascular occlusion, and vascular occlusion, if you've got no blood supply, the nerve tissue withers away. And so these are the OCTAs and the surface map of sickle maculopathy, very, very common or in Southeast London. But if you don't practice in London, you probably would never see a sickle case. And then you get this capillary dropouts, primarily in the deep capillary plexus. So again, we have to bear in mind that there are 3 layers of cells. There's a superficial, intermediate, and deep capillary plexus. And I'll show examples as we go along as to what abnormalities in these different layers can look like. So again, we're just going layer by layer. So the difference between an epiretinal membrane, which is now in this case partially separated, is it hasn't got that thinning out and change in the foveal contour. Now, there is some corrugation here because of spontaneous separation of an epiretinal membrane. There's a little bit of a vitreous macular adhesion there. It's not traction as such, because it's not hugely distorting the profile or thickening the retina. So again, the foveal contour is irregular, it's corrugated, probably because of this posterior hyaloid, which is partially separated. And you can see there's a split in this outer bit. The epiretinal membrane is slightly separate as a structure. The other structures are all largely intact. Nerve fiber layer is intact, so the optic nerve is healthy. The banded structure of the retina, the 2 plexiform, the 3 nucleates are all intact. And the outer retina possibly is disrupted. And that's a key thing in patients who've got vitreomacular traction, because vision is only really going to get disrupted when patients start compromising their outer retinal structure as a result of that pull from vitreomacular traction. But the VR surgeons are very unlikely to do anything in the situation unless someone's experiencing distortion. So unless it's broken through into a full thickness macular hole, they're usually left well alone. So again, take a moment just to look through that using that structure approach. So 1, look at the foveal dip. 2, look at the nerve fiber layer, and then look at the banded structure. So the plexiform layers and the nucleated layers and the outer retinal structure. So if we go backwards, the choroid's okay. The outer band is largely okay. There's possibly a change here. The nucleated layers, outer nucleus is always thicker than the ganglion cell layer, and the bipolar should be the thinnest layer. So if you look here, the bipolar looks slightly wider than the ganglion cell layer. So we know something's going on there. The foveal contour looks largely okay, but that white wedge, which we should be seeing, just going back to the last one, that big white wedge of the nerve fiber layer is completely absent. So this patient would have profound vision loss, and this was a case of nutritional amblyopia. Again, the condition doesn't really matter, but whatever optic neuropathy there may be, if it's toxic, nutritional, or from vascular event, or whether it's from glaucoma, whether there's loss of ganglion cell layer, all ends up looking the same, where you lose that nerve fiber layer. And again, it's missed in clinic over and over again, these subtle changes, because sometimes the automated segmentation just totally misses this, and we'll just call this as the posterior membrane, as the inner limiting membrane, rather than that thing there. So again, you've got to look at the automated segmentation as to whether it's correctly interpreted the layers. So you can't totally rely on that. So again, you can do the OCT on lesions away from. So as we were talking about the nerve fiber layer, you can see there's a little bright white thing there, which is a slightly feathery edge pointing towards the disc. So that pointing towards the disc is a little bit of a giveaway. We think it's superficial. And we can see here that in the nerve fiber layer, so normally it doesn't look quite as bright. It's just a little cluster of myelinated nerves. So again, you can change the orientation of your OCT scan to the point of interest if needs be. Again, this is of no pathological significance, but there would be a blind spot in that area because that inner retina is opaque. And then just make a note of what the optic nerve sort of looked like. It looks generally a little bit elevated just out these upper and lower poles. So again, same approach in here. We get some little clues going off this infrared picture that there's a little dark shadow. And if we look at the structure of the retina, well, the foveal profile is slightly abnormal, so there is some contracture there. The nerve fiber layer is intact, but very, very irregular. And then we see all this extra stuff. If we look at that, I'll have to find you. Yeah, okay, there's the next one there. So a normal optic nerve cup is flat and deep without glial tissue within. And if you can see here, there's all sorts of noise and signal. It's a little cobweb of stuff and a thickened hyaloid, and there's debris in the vitreous. If we look at the banded architecture, those lines are in continuity largely here, a little bit corrugated, probably because of that pull, and then quite disorganized here. So this is, again, not so important as what the problem is. It's proliferative diabetic retinopathy, but we can just pick up the changes. So we know much more about the diabetic retinopathy. This retina is obviously very ischemic. There's a dark blot hemorrhage peripherally. There's not too much else going on that infrared picture, but those blood vessels distorting the nasal bit of the macula, but this outer temporal bit, where you've got disorganization of the retinal layers, where this banded regular architecture is lost, is very characteristic of ischemic maculopathy, which is a very common cause of poor vision in diabetic patients. So we know this patient hasn't got diabetic macular edema, but they probably have got diabetic macular ischemia, which is an equally common cause of poor vision. There's not a lot you can do about that in actual fact, because it's lost blood vessels, and once blood vessels are lost and the nerve tissue withers away, it's gone and gone for good. So normally at the center of the disc, you don't really see any detail. This is a very early bud of neovascularization. We won't dwell on that. Just want to go on the contour of the nerve. Normally it's flat. So if it isn't flat, then again, this is a really sort of critical thing, a swollen nerve. So this example of a nerve shows a very, very elevated nerve. And sometimes you can see fluid pockets within. This picture is not so clear because the patient had some lens opacity, but there's more going on in this eye. This patient was part of one of our genetic eye disease clinics. So if you look at the banded structure, this is the bit going straight to the center of the fovea. We can't see the fovea on there. The nerve fiber layer is intact. The banded inner structure is there, but the outer retinal triple line with the external limiting membrane is very, very irregular. This patient had a retinal dystrophy, a rod cone dystrophy, but was very overweight and had idiopathic intracranial hypertension on top of their rod cone dystrophy. So that's just adding insult to injury. If you have a optic nerve pathology as well, it will probably just accelerate the vision loss. So again, another macular OCT scan, just have a little look, try and work out what's going on. So are we at the foveal center? No, we're not, because we don't see the dip and we see the banded structure going across. Little changes in the vitreous are some separation. Banded structure, well, yeah, we can identify dark bands, but we're slightly away from the foveal center, which is there. So we just want to look at the outer retinal structure, the choroidal structure, which all looks okay. But what on earth is this thing? Well, there's some glaring abnormality on the optic nerve. But what we said right at the beginning is certain things look brighter than others, and certain abnormalities show shadowing as well, because this scan is based on the reflectance of light and absorption and passage of light. So it's a very, very bright white signal off the surface and total shadowing and non-penetration of light behind. It's a black pigmented mass of the optic nerve head. So the thing we think about, is it malignant or is it benign? This is a benign tumor, something called a melanocytoma. And it has this very, very characteristic appearance where bright signal, very black lump at the back of the eye, often of the nerve, but it can be at the macula or the posterior pole or on so anywhere where there's uveal tissue, you can have a melanocytoma. But it just shows that, just to show an example of shadowing. So there is no penetration of light and just bright reflectance of pigment. Pigment generally looks bright white, just like the pigment epithelium looks bright white. So looking at this scan, are we all still okay? No one's fallen asleep or any questions?
We're all engrossed,
Yeah.
actually.
Okay, fine.
That being said, I did want to ask the participants whether they're comfortable with the talking still continuing, or whether there was any questions. Did anyone else want to ask a question?
Because the other thing we can do is, if we were scheduled just for an hour today, is I'll just do a few more scans and we'll look at the case, and we can continue the other half of this talk as we go through the layers next time, just so we don't go on far too long. So
that sounds good.
sure.
We are at sort of 7 minutes to.
Yeah.
So a couple more slides and a case. We may just end up overrunning, so I hope the participants are comfortable with
let's
that.
just see how many slides we've got. Yeah, there's about 20 slides left on this this talk overall. So it depends on what everyone wants to do, really.
So keep
I mean,
going.
I'll be guided by you. Well, any comments? Does anyone want to say?
So some people, one person said all good. I think maybe just let's keep going, and then we'll do a couple more slides and do a case, and then if people want to continue, we'll continue, and if people want to continue with the rest of it next time, then we can do it next time.
Yeah.
I've had one vote for keep going, by the way.
Oh, okay. That's one. 38 for not, 37 for not keep going. So we'll go with the majority.
Okay.
Okay. So again, just spend a moment looking at that scan. See what you get some information off the infrared picture as well. But just look at that picture. Does it look? I think we're all sort of recognizing that pattern. It's obviously abnormal. So the foveal dip is there. It's very clearly there, but it looks slightly more accentuated, and that's probably because the whole structure of the retina is thicker. Now, it can be thickened for many, many reasons. You can have macular edema, and macular edema can be fluid, or you can just have a diffuse engorgement. Particularly, there can be edema from leakage, so that's vascular edema, but there can be a cellular edema as well, where the whole thing just swells up. So if we look on this, so foveal dip, yeah, abnormal, but it looks steeper and tighter. Well, let's just go back a couple of slides again. That's a normal contour where it just follows that sort of pattern. Just get that laser pointer on again. And then just coming back to this picture, it looks very, very different. It's just tight and deep. So in nature, it would be something like a hawk, which would have a fovea with a depression like that. So it's just all compressed in. So the nerve fiber layer is intact. If we look at the plexiform layers, actually that one's in continuity. Slightly odd signal there. That one's in continuity. And then the nucleated layers, well, that outer bit looks okay. That's already telling us something, that the outer retina is intact, but the inner retina is very not intact or not quite right. So these are all much brighter than normal. So that's a much brighter signal. Normally we said the nucleated layers are dark, but here it's gone very white to the same sort of level. So if we look at that picture, we can see dilated tortuous vessels, and then just a territorial change. There's a shadow going on. There's something else going on here. There's an increased transmission. So this is a cherry red spot, not from a central retinal artery occlusion, but a ciliary retinal artery occlusion. So about 1 in 5 patients will have natural ciliary retinal artery occlusions. It's a low pressure system physiologically, and just that back pressure of high venous pressure from a vein occlusion can sometimes be enough to shut the ciliary retinal artery off. Again, you don't need to know the complexities of the problem, but it's just recognizing infarcted tissue looks white. So any acute arterial occlusion, in a venous occlusion, you get edema typically. Well, you get hemorrhage, sometimes general engorgement, but you never get a whitening of the tissue. Any whitening of tissue generally is problematic. So this is the inner retina. It's a ganglion cell layer which has been infarcted. So it's got to be this very superficial layer of blood vessels. And if we look here, it's the same eye. A few months later, yes, that was February 2019, and that's September 2019. And you can, so we'll apply the same approach. Is the dip there? Well, not really. That's because the inner retina is completely disintegrated. The nerve fiber layer really can't be recognized at all. The plexiform layers can't be recognized, but the outer retina structure can be. The outer plexiform layers, the outer nuclear layer is intact. The highly reflectile outer retinal bands, there's a triple line there. The external limiting membrane is intact. There's pathology, so again, not all the banded structure is always going to be there. It depends on the age of the patient as well. You'll see that triple line clearly in a young patient. That choroid looks distinctly abnormal too. It looks very, very thin. Normally we said the choroid is about the same thickness. Would you see if that was thicker before? Not really. So there was some sort of choroidal sclerosis or choroidal insufficiency. So that is the late complication of any arterial occlusion. And sometimes vein occlusions end up becoming atrophic in the inner retina too. So again, there's never going to be any recovery because the photoreceptors are all there. They're nourished by the choroid. So they're still being kept alive, but there's no way of that photoreceptor layer or outer retina then communicating the information back, processing and communicating the information back by the bipolars and ganglion cells. So no surprise that this patient is going to have vision in the order of hand movements or thereabouts, or the peripheral vision will be intact, but obviously the macula has been destroyed by that ciliary retinal artery occlusion. So we're almost 8 o'clock. So should we stop there and then we can?
So people have asked to keep going.
Oh, okay. Right. Okay. Well, it'll be another 20 minutes or so. So if everyone's happy to go, okay. If you need to go, then feel free to go. If you've got any questions, 2-minute break for questions now.
Any questions? There's none in the chat so far. If you want to unmute yourself and ask a question verbally, you're more than welcome.
Nothing in the chat. Okay.
No. Nothing so far.
Okay.
Let's keep going.
We'll keep going then. Okay, we're just going through the layers, so we're just going to, no surprises in guessing that we're going to probably go to the outer retinal structures now. Okay. Why have I frozen? Here we go. Okay, yeah, okay. So look at the infrared again here. So again, we're just looking at localization of different layers. Again, the condition doesn't matter as such, but what's obvious is the retinal veins, again, are very dilated and tortuous. So the foveal dip intact, no fiber layer intact. Disc is slightly swollen, as is often the case in a vein occlusion. And then look at the plexiform layers. So the sort of tram track is in continuity there. Very odd in there, but you can see a shadow in that area as well. And if we look at the outer structure, intact, but what we've said is if there's other pathology going on, you get a disruption. If a patient's elderly, you don't always see the third band, but we can certainly see the ellipsoid line intact and in continuity. The pigment epithelium is in continuity. It's always a little bit wider there. The external limiting membrane is also intact. The choroid is intact. It's not completely normal structure, but again, you need to know the refractive status of the eye. There's that little sort of curvature which suggests the patient's myopic, and myopes generally have a thinner choroid as well. So what we can see here is a distinct opacification in a very localized area in the bipolar layer only. So what we know and it's a very much an OCT diagnosis. This is called PAM, paracentral acute middle maculopathy. And what the OCTA is taught us, something we couldn't visualize ever on fluorescein angiography because you could never see superficial, intermediate, and deep capillary plexuses on that. But on the OCTA, we know this is a specific blockage at the level of the intermediate and deep capillary plexus. And the mechanism of developing sickle maculopathy is multiple small areas of PAM. So we see PAM in a whole bunch of conditions, in CRVO, in giant cell arteritis, in sickle, and sometimes idiopathic and spontaneous for no apparent reason. Certain drugs, cocaine, high caffeine intake, various things can cause localized watershed infarcts, essentially what these things are. And the normal natural history of PAM is this will thin out because anything which causes essentially an infarct just causes atrophy. This is central nerve tissue, which is externalized, and central nerve tissue has no power of regeneration. So again, very similar appearance, again, dilated, but this again is just a beautiful example of the physiology of the eye. So we know there's territorial blood supply. So we have the superior and inferior temporal vascular arcades, and there is a watershed. So the top vessels never cross over, and the lower vessels never cross over, and there is some structural weakness. So a lot of diseases end up primarily showing changes. So sickle always shows up here. Diabetes often primarily shows up in the temporal vessels. Macular edema is often slightly more engorged in the temporal vasculature as well. So what we can see is little dark things. Well, dark things are either hemorrhage, which are isodense with the retinal structure. But what we can see here is just distinct changes in exactly the same Sorry, was there a question there?
No, I think it was
okay.
just someone off mute.
Okay, yeah. So again, in that PAM case, we see a sort of slightly wider area. This is essentially the same thing. It is a back pressure related thing, but we'd call these sort of territorial watershed infarcts, but actually small multifocal PAM is the same thing. So that thing is probably hemorrhage. That's what a hemorrhage looks like on an infrared reflectance. But this is the watershed. This is where there's capillaries only. There's no large bore vessels, and really it's only capillary flow which nourishes that horizontal raphe. And if you've got back pressure on the venous supply, it can just shut off the capillary bed. So it's a watershed territorial infarct in the deep and intermediate capillary plexus. It does, again, the complexity doesn't matter, but it shows us some physiology and structure of the retina and just how precise we can be with the localization of what's going on. Okay, so another case, we'll just go through that same approach. Is a foveal dip there? Well, no, it's not, but there's multiple pathology going on here. Firstly, there's an epiretinal membrane on that ILM level. The optic disc is a little bit swollen on that picture, very engorged vessels. So that could be because there's a vein occlusion engorging everything, or it could be a very profound epiretinal membrane just disturbing the profile. But it isn't very corrugated, so there's probably dual pathology there. There's an epiretinal membrane. That may be very chronic because you get chronic seepage and epiretinal membrane formation, or it could be the vein occlusion with a subtle epiretinal membrane. You really can't tell. But if we look at the nerve fiber layer, it's intact. Plexiform layer, well, it's identifiable in places, but very fragmented, so continuous there. And then we see little pockets of fluid in the nucleated layer. And those pockets of fluid really never go external to the external limiting membrane. That's a physiological block. It's the outer limiting membrane. There's the inner limiting membrane and the outer external limiting membrane. So fluid doesn't go beyond that. Same with exudate. Exudate doesn't go beyond Henle's layer, generally speaking. So these things get localized to particular layers. So there's intraretinal cyst, and there's also some subretinal fluid. So again, macular edema, the first change you'll see is a diffuse engorgement. So if you do your color map on an OCT, the colors go from green to slightly orange or red. Intraretinal cyst is a further destabilization of the seesaw, and then when it gets really gross, you'll see subretinal fluid accumulating too. So we said there's multiple pathology because slightly swollen disc, epiretinal membrane, evidence of vein occlusion because there is macular edema there. But we can't be absolutely sure unless you look that there's hemorrhages in all four quadrants, but it looks very much like a vein occlusion. But there's also gross pachychoroid changes as well. So it's a super thick choroid. Again, normal choroid should be, that's 200 micrometers. Sorry, I'll just get that pointer. No, didn't mean to do that. Lost my laser pointer. Okay. So multiple changes going on there, and they're all. Well, my computer's frozen, so I'm just going to have to stop. Give me 2 secs. I'm not quite sure what's.
While you're doing that, I'm just going to open up the floor. Is everyone happy? Do we have any more questions at this stage? We have a very silent audience.
Yeah, maybe we should pick on people. Okay.
Oh, I love picking on people.
Well, we'll be gentle this time, otherwise no, we'll come back for the second one. Okay, same approach on this one. So this is going absolutely through the middle of the fovea. You have to say my word for that. So the dip is irregular, nerve fiber layer is intact. Plexiform layers in continuity largely, but there is an abnormality in the nucleated layers. Outer nuclear layer is largely intact. Overall retina looks quite thin because normally it's about 300 microns, and that. Yeah, so there's 200 microns there. So there is a global thinning. As we said, the outer nuclear layer should be the thickest bit. But we see all these little cystic cavitations going all the way across the retina. But it looks very different to that one. There are also cystic cavities, but this is in the outer nuclear. This one's in the inner nuclear layer. So this is a case of retinoschisis. So it's X-linked retinoschisis. Again, not so important where the changes are, but it's just describing that we can pick up. So we know exactly what this patient will have. Specifically, their gene mutation will be in the retinoschisin RS1 gene. We know exactly which codon it will be and in which exon the changes will be in, because 99% of mutations are in the 4th exon. So we can do very targeted molecular testing just based on that single OCT scan. So there is a beauty in certain phenotypes and genotypes being highly correlated. So again, have a little look at that. Just have a think. See if you can work out what on earth is going on here. So foveal dip, good. Perhaps a bit broader. Nerve fiber layer intact. Slightly elevated disc. So that may be atypical. We've not got a scan through the disc. Now, the plexiform layers, now we don't really know what's going on. So that line there is probably the outer plexiform because it's going into the fovea, but that fovea looks very, very thinned out. Now, the nucleated layers, what can we do? There should be 3 dark bands. So 2 bright bands are the plexiform layers, the 3 bright bands. So the ganglion cell layer is probably there. The bipolar layer is probably that one, but the outer nuclear layer is completely gone all the way across. If we look at the outer retinal structure, remember that tells us the ultrastructure of the pigment epithelium, the outer segments of the photoreceptors, and the ellipsoid, the powerhouse of the cell, really not identifiable. So this retina has got problems, all localized to the photoreceptors. So we can't see the photoreceptor nuclei, we can't see any of the ultrastructure of the outer segment tips. And then if you look at this choroid, it looks different to other patients. There's a choroid there, so that pigment epithelium is intact. This one is super bright. The pigment epithelium is gone, so you get increased visualization of the choroid. So that's why the vascular detail looks slightly anomalous. So this is a patient with a rod cone dystrophy, or retinitis pigmentosa in old money, where the rods and cones have been totally destroyed all the way across. Look at this one. What's the difference between that one and that one? Have a little think for a minute, see if you can work it out for yourself. So again, dip is there, but blunted. Nerve fiber layer is intact. Look at the banded architecture. So we are the foveal center because the plexiform layers are sort of coming to a point there. So the plexiform layers are intact. The middle bit there, the fovea, looks largely normal. So what do we know about the fovea? It's where the cones are. The rods really start in their peak concentration, so that's 20 degrees across. In their peak concentration, about 4 degrees off center. And what happens there? So actually the photoreceptor nuclei, same like the other eye. This one we said was a rod cone dystrophy, where the rods and cones have all just disintegrated to nothing. Well, here the cones look very much intact. Even the triple band is present. This is a young patient, but the rods have completely gone. Now there are cones out the macula as well, but there's often an interdependent survival. So if the rods die, the neighboring cells often die as well. So this is a very classic appearance of a rod dystrophy, so not without cone involvement. So they have profound nyctalopia, but actually their daytime vision is not too bad. So just use the same approach on this one. Have a little think for a few seconds. Is it jumping out at you as what's obvious? Well, there's quite a few things to pick up. There's a bit of debris in the vitreous, a little bit of separation of the vitreous, possibly an epirostral membrane, or maybe just a reflex. Foveal dip is okay, nerve fiber is okay, the inner retina is largely okay, but we've got a disruption of the outer retina. Again, a slightly anomalous vascularization appearance of the vascularity. Now, remember we said the nucleated outer nucleus should be the thickest nucleated band. The whole retina looks thin, and it gets very scrambled here, the outer retinal bands, that triple layer, really from that point, well, all the way to the middle, is difficult to discern. So there, it's almost like you can see Brooks membrane. You've got these little lines. That transmission defect tells us the pigment epithelium is ropey. So just like this patient where we said had a rod dystrophy because there's only rods at the center, what we know is in the middle is cones only. So this patient's got a cone dystrophy, the sort of inverse. So the cones undergo degeneration, but the rods are spared. So the peripheral retina, where there's a high concentration of rods, look relatively spared. The photoreceptor outer structure is largely intact, but there's an overall diffuse thinning of the central retina. Again, see a little bit of a variation. So of the same thing. So in this case, the foveal dip looks anomalous, looks very blunted. So again, you have to ask that question, is something pushing it up or something dropped down? So we use the same approach, nerve fiber layer intact, but possibly attenuated. Plexiform layers intact. The nucleated layers all look quite thin. But if you look at the structure of the outer nuclear layer, it's broad, and then it goes very dim, and then it's broad again with central sparing, and then it's thinned out again, and so it goes wide and in and out and in. And if you look at this infrared reflectance, you just get the vague impression there's a circle there, and there's another circle there. So there's a bullseye maculopathy. There's many reasons for a bullseye maculopathy. It could be tamoxifen retinopathy, hydroxychloroquine retinopathy. It could be cone dystrophy as well. I think this patient was a hydroxychloroquine retinopathy. So we obviously have a screening program at St. Thomas's for all those patients, the rheumatologists and dermatologists put on hydroxychloroquine. So it is an issue when it happens. And again, we're sort of traversing our way through the retina. We're now worked our way into another space. So dip is there, but it's been distorted. Nerve fiber layer is intact. Disc, probably crowded, small disc. So a crowded looks like a swollen disc sometimes. Partial vitreous separation. Retinal structure looks okay. But if we look at the outer retinal bands, that triple line, the interdigitation very discreetly gets broken there to there, but the ellipsoid is intact in continuity, possibly a little bit of disruption and attenuation, and the external limiting membrane is intact, and the pigment epithelium is in continuity. So we know this is in the subretinal space, and it's a whitish mass. It's a very, very typical appearance of the adult vitelliform macular dystrophy. Best's disease looks the same. It's more about localizing to the space. So that's something solid in the subretinal space. It's lipofuscin. If you did an autofluorescence image, it would glow absolutely bright white. So again, if it's Best's disease, juvenile Best's, it tends to be a little bit wider and broader with a positive family history. In adult onset vitelliform, the family history is often not so clear, but there is undoubtedly a genetic basis to that. There's 3 or 4 genes that we know are associated. They tend to be much milder mutations. The choroidal structure is intact. Now, this case is exactly the same layer. We said the pigment epithelium is intact. And that's how you decide whether someone's got a pigment epithelial detachment or not. So if you thought that was a pigment epithelial detachment, it's incorrect because the pigment epithelium is still flat and in continuity. This one, the pigment epithelium is also flat, and then the ellipsoid gets broken. So we can tell things from that as well. So this is black in exactly the same space. The choroid probably looks slightly thickened. That's probably just a premacular bursa in a young patient. But the retina is all thinned out. The outer nuclear layer is thinned. Partly that's because it's stretched, but partly because it's chronic. So this is central serous. This is fluid, central serous chorioretinopathy. We do call it chorioretinopathy rather than retinopathy because the primary pathology is in the choroid. It's a dysfunctional choroid, which then causes dysfunction of the pigment epithelium and its pumping mechanism, and then an accumulation of fluid overlying that. And we can tell other things. We know this is chronic because the outer nuclear layer is thinned out. So that only happens when it's persisted 9 to 12 months or longer. This debris on the inner retina means it's been separated for at least 4 months for that accumulation to develop. So that's subretinal fluid in the outer retinal space. Now, this one, again, looks almost identical, but with a mix. There's a debris in there. There is fluid in there. It's the same sort of elevation and blunting. But in actual fact, if you look very, very carefully, pigment epithelium is intact, but there is still a banded structure. So remember what we said right at the beginning, there is ultrastructure in the retina. We do recognize the ellipsoid line. It doesn't look quite as bright because the tissue overlying it is abnormal. This retina all looks abnormal. So the nucleated layer has gone opaque in there. So there is a photoreceptor pathology going on there. That ellipsoid is probably in there, but there's some disturbance of the outer nuclear layer. And this is something called a bacillary detachment, which happens in inflammatory diseases. So this patient's got MUDs, placoid, AMPI, acute multifocal placoid pigment epitheliopathy, but a number of other inflammatory eye diseases, chorioretinopathies can end up with the same sort of thing. And this is a separation, not in the subretinal space, but where the myoid, so where the Golgi apparatus gets separated and not in the subretinal. So it's not the interdigitation. There's something peculiar about the condition which destroys the structure of the photoreceptors. But again, it's just seeing the detail. So have a look at this. This obviously jumps out as most of the structure looks totally normal. The fovea is thinned out. The nucleated band should be thickest at the foveola. and there's black in the middle, and there's a very crisp truncation of the ellipsoid and the interdigitation. So this sort of facet defect is very pathognomonic of solar or photic retinopathies. That could be a laser burn. We've seen it in kids with laser pointers. We've seen it in people who've stared at the sun for whatever reason. I'm not quite sure why you'd want to stare at the sun. Everyone says at the eclipse, don't look at the sun, but this is either an eclipse or a laser pointer maculopathy. Again, don't need to know the thing, it's just more localizing the disease. So we'll whiz through these last few. Won't torture you too much in it, but now we can see, we said there are 4 bands that we normally identify. So we see the pigment epithelium, the interdigitation, the ellipsoid, and the external limiting membrane. But if the pigment epithelium gets lifted off here, so this is a shallow, irregular, drusenoid pigment epithelial detachment with coalesced drusen, you can then see the pigment epithelium, sorry, the Brooks membrane, which is a basement membrane of the pigment epithelium. And then you can see the choroidal detail underneath. So this is just an example of dry AMD. And we can see lots from the infrared reflectance. We can see bright white specks, so that's focal hyperpigmentation, which is an additional risk factor. These drusen are big, so that's 200 microns across. Remember, the OCT scan is stretched to make it easier to interpret. So vertically, 200 micrometers is that line of the L, and then the horizontal, the much shorter bit, is 200 micrometers across. So on the AREDS classification, we'd say someone's got high-risk drusen if it's more than 125 microns. These are obviously much larger than 200 microns, and we'd say something by definition is a drusenoid pigment epithelial detachment if it's more than 350 microns. And this sort of mottling is something called subretinal drusenoid deposits, which are drusen in the subretinal space and not under the RPE. They're different, have different risks, and we'll talk about them next time when we talk about AMD. And usually in this patient, for AMD, it's got a slightly, it looks like a thickened choroid. So there may be some sort of pachychoroid spectrum disorder going on as well. But that appearance is very, very much so dry, extensive, widespread AMD with multiple risk factors, large drusen, pigmentation, subretinal drusen deposits as well. So they're much more prone to developing atrophy and neovascularization as well. So again, similar appearance. There is now, we said this was a drusenoid and solid. So you can have multiple pigment epithelial type. You can have solid from tumor. You can have serous from fluid, like this. You can have drusenoid from drusen. And then other things can elevate the pigment epithelium as well. So this is a serous detachment. This clump here is the same here. So drusen get deposited at the basal lamina of Brooks membrane, remembering that's a sandwich of collagenous and elastic layers of the of tissue. It splits Brooks membrane apart. So there's a weakening, so the pigment epithelium can go off. Whenever we see a pigment epithelial detachment like that, you can see a great big shadow. The assumption always is, again, there's drusen and this stellates pattern tells us there's been a solid pigment epithelial detachment. But if there's a serous large detachment, we've always got to look for a neovascular component. So usually there's some sort of notch, and usually in the notch, so again, there's a sort of smoothish, there's a notch there, so there could be neovascularization there. And again, it's a little bit irregular, so there's a smoothish circular contour all there. Here it's a bit jaggedy. Almost certainly there's a small neovascular complex driving this whole thing. So you can't make an assumption unless they're completely angiographically inert on a fluorescein that there isn't any neovascularization. So that patient should obviously be referred with a matter of urgency. These things tear off quite rapidly, and when they get steep, you can get a rip of the retinal pigment epithelium. So if you look at this case, which is a pigment epithelial detachment, this is also a pigment epithelial detachment because you can see Brooks membrane there, and the pigment epithelium is irregularly elevated. So that's one thing. The subretinal space has got black there, but this is all semi-opaque. We can see a dark shadow. So what we can see is there's blood in the subretinal space. There's a shallow, irregular pigment epithelial detachment. So the assumption is this patient anyone with a irregular detachment is polypoidal vasculopathy, again, something we see overrepresented in southeast London because of the Afro-Caribbean population. So again, if you look in detail in that pigment epithelial detachment, you can see a little circular lesion there. There's another little circular lesion there. There's another little circular lesion there. So within the change, you can start seeing these things. We're not just imagining them. When you scroll through, it's much more obvious. You can manipulate the images, and that's polyps. So that's a highly volatile, very, very destructive process, typically in hypertensive African Caribbean patients, but 20% of Caucasian patients with neovascularization will have evidence of PCV, and you can see it as part of the pachychoroid spectrum. So this patient actually had CSR. As a complication of their CSR, they developed a hemorrhagic PED. So again, going back to my favorite subject of genetics, so we can see a shallow irregular elevation. This is away from the foveal center. Most of the renal structure looks okay. There's some irregularity there. That's probably pigment migration. But if you see here, Brooks membrane looks really obvious. There's only a couple of conditions. So if you look at, if we go to Brooks membrane here, it's not so bright. In this case, Brooks membrane is not so bright, but in this one, it is brighter and thickened. So there are a couple of genetic conditions, pseudoxanthoma elasticum and Sorsby's macular dystrophy, which give this, again, genotype-phenotype correlation. So again, we can tell where the gene mutation lies in this patient. They presented, it was someone in the 30s with macular neovascularization. And then just looking at it with these coalesced drusen and that thickened Brooks membrane, we pretty much know what that diagnosis is going to be. Again, just for going, are we still going on? There's not too many more, so hopefully we'll finish by 8:30. Again, I'll just whiz through. So most of the retina is okay. We've moved through to the choroid now that we've identified Brooks membrane. So if you look at this choroidal structure, we've said there should be large bore, medium bore, and small bore vessels, but the choroidal appearance gets very disrupted here. So we've said pigment is normally bright. So that's got to be pigment because it's bright, or likely to be pigment. There's a few drusen over the surface of it, but there's no fluid and it's completely flat. That's a choroidal nevus. So we monitor nevi now by, if they're at the posterior pole, we will do an OCT over them. So not just doing the OCT looking for elevation or evidence of malignant transformation, we get very, very detailed evidence of change on the OCT, but this is completely flat. The things we look for is fluid, orange pigment on an autofluorescence image, drusen, but subretinal fluid and height. Now, traditionally, it used to be 2 millimeters of elevation, but that's 200 micrometers, not 2 millimeters. So we can pick changes up very subtly and early. Similarly, again, there's choroidal pathology because there's some normal changes, very undulating retina. There's a few other things going on. Partial detachment, retinal structure looks slightly odd, but that's because we're a long way off center on the infrared reflectance. Big, wide disruption. There's a few little stalactites telling us there's chronic separation. We can see Brooks membrane as well, and there's a shallow, irregular, widespread so-called double layer sign that often implies there's some neovascularization going on. But the choroidal structure, so it's not bright white, but we don't see the vascular detail in here as well. This is an osteoma. An osteoma is the development of bone. It's a hamartoma, abnormal tissue, normal tissue in an abnormal site. So normally you don't get bone in the choroid, but again, it's just showing in various layers we can see various pathologies and just localizing and making some sort of sensible conclusion as to where the pathology is and what it potentially could be. Because you can sort of look that there's a diffuse widening of the choroid. When there's fluid, we just always make an assumption. So if you see fluid over a choroidal lesion, assume the worst, that it's something nasty. Because if you see any choroidal mass, the first thing that should go through your mind is it a melanoma or is it a secondary metastasis? And the presence of fluid is another indicator of that. It was by a process of elimination we decided that that was an osteoma. The appearance is usually a giveaway. Again, this is another choroidal mass. So again, we showed you pictures of a myopic staphyloma where everything caves away. In actual fact, this bit here is the normal bit, and this bit is elevated. So in the last picture, we said the choroidal detail is lost. In this one, we can see vascular detail. So on that picture, there's a dark shadow. So that dark shadow tells us there's an elevation. There may be some hemorrhage. There's some disruption of the outer retinal structure, which tells us a very chronic process. Some of the retina looks healthy. This is a choroidal hemangioma. So this is a tumor of blood vessels. They're benign, but they can decompensate and start leaking. And they're very easily treated with PDT. So you can get circumscribed localized hemangiomas like this. This infrared reflectance gives us some information that there's probably been some chronic leakage. There's probably been some gravitational fluid which can wax and wane. So we'd be much more likely to treat a patient because some of the outer retinal structure has been lost. So there's undoubtedly been some leakage in that. But we can localize and just guess from the OCT that this is a vascularized mass rather than a pigmented or solid mass. So again, super helpful. And we'll just jump straight ahead. This is just a thickened choroid. So we said normal choroidal structure. Again, on an EDI, there's got large bore, medium bore, and small bore. And you can just see here that there's a very localized dilatation. So this is pachychoroid disease. So CSR really is the pachychoroid condition, or the number one pachychoroid condition. But you can have pachychoroid pigment epitheliopathy. You can get pachychoroid PCV. You can get pachychoroid neovascularization as well. So there's a few things that happen on the pachychoroid spectrum. This patient's got pachychoroid changes with PEDs, and this patient eventually decompensates to developing classic CSR. But we do really look for choroidal vascular changes. And on an ICG angiogram, this will be very, very dysfunctional choroid with inner-choroidal ischemia. Because whilst these are shunt vessels in the outer choroid, the choroid capillaris gets destroyed. So there's inner-choroidal ischemia, and the pigment epithelium then decompensates. And then this is just a late change of an elderly patient with pachychoroid vessels. So there's only large bore vessels, only Haller's layer, Sattler's layer, the medium bore, and choroid capillaris is just totally disappeared in this case. Okay, so I think we've gone through a crazy number of cases, but it was really just about showing not diagnoses as such, but changes happening at every layer and the different types of changes you can see. So hopefully you have a good structure. I'm sure most of you did anyway, but you have a structure and a handle to hold on where the changes is happening, what sort of tissue is there, is something present or absent or missing, and then you can make a pretty educated guess just based on those findings as to what's going on. So just remember that 1, 2, 3, 4 approach if you're really stuck as to what's going on. Okay, I'll stop there. That was way too long. Sorry.
Oh no, it was amazing. Thank you so much. Learned so much from that. There was one question that's been was raised a bit earlier when it was when you showed the swollen disc and you mentioned it's probably actually crowded just because it's small.
Oh, okay. Yeah.
And so the question was really, how do we differentiate a swollen disc from a crowded disc or a disc with drusen on OCT?
Yeah, so you can tell the difference between all of those things. So an acutely swollen disc clinically will have little hemorrhages alongside it, or not if it's an anterior ischemic optic neuropathy and it will be pallor. But if it's an acute swollen disc, you'll see edema. So you'll see little pockets of fluid and possibly subretinal fluid. Now, if it's optic dystrusion, they look different. And again, maybe I'll just write these things down, or Bhavin, if you keep a note of the, you have the questions, and then perhaps next time we can show examples of these conditions. Yes. But there are a number of conditions where you get cavitary changes. So you get optic disc abnormalities where there's cavitations, things like coloboma. You can get optic disc drusen, which can or sometimes not autofluoresce on autofluorescence imaging, but they're very discrete little dome circular opacities in the optic nerve head. So they look completely different to a swollen disc, which has little tiny pockets of intraretinal fluid, whereas these are defined solid structures. And there's this thing called PHOMs as well, peripapillary hyperreflectile ovoid bodies, which are on that continuity of disc drusen as well. So disc drusen tend to be lumpy, bumpy, buried axoplasm within the disc body. PHOMs are slightly more
Ovoid.
yeah, more ovoid and lighter in color without that reflectance pattern. An acutely swollen disc will have some fluid, which is black alongside it, whereas a crowded disc won't have fluid. So that's a basic symbol. And then using your caliper, just measure the linear diameter of the disc. Don't rely on the automated segmentation to say, oh, it's a small disc or the vertical disc diameter. Most crowded discs and swelling from crowding will tend to be vertical disc diameters of less than 1.6 or thereabouts.
Amazing, thank you. Was there any other questions? Not at this point. I'm going to run the poll at this time, just because we still have most of our participants, and it's just a quick sort of double confirmation of your name, your GOC number, and your email address. I'm not sure if everyone can see that. Can everyone see that? Or I think we're still sharing your screen.
I'll stop sharing.
Thank you. So is everyone able to see the poll? Oh, yes, I've got people answering now, so that's great. Amazing. A few yeses, a few nos. Okay.
And I think at some stage we loosely discussed with Bavina that we may end up forming some sort of informal rapid access OCT interpretation service if that's something people are interested in doing. So if it's something that's a diagnostic challenge, if you want some sort of advice, we'll try and develop some sort of rapid response service where we can just advise as to what to do if people are interested in that.
Lovely. I'm going to leave that poll running in the background. Did anyone have any cases or pictures they wanted to just put forward to Mr. Mohammed at this stage? No. Can I share my one? Is that okay?
Is the person that submitted this one willing to talk about it, or?
So she's given
Do we
me
know?
the information. I've just
Oh, okay.
basically put it on the slides. So I'm going to just quickly show, if that's all right. So for everyone else in the group, just to let you know that this patient presented, it was a 73-year-old presented to the practice. They were new to the practice. They had uncomplicated bilateral cataract surgery in 2022. They had been previously diagnosed with macular degeneration, dry and early form. And they attended reporting a decline in their central vision. When their quote words were, they had difficulty recognizing faces. When the examination was carried out, the optom found the VAs were 695 in both eyes. There was no improvement on pinhole, and there was central amular distortion. This was his general screening fields that we did. And obviously very central. Here was his right OCT macular scan. And this is the foveal profile. Can I pass it over to you, Mr. Mohammed, just to give me some sort of interpretation of it?
Or does someone else want to chip in, or does anyone else want to have a feeling confident enough to have a little go? And
Let's see.
can you zoom in on that a little bit, because it would be good to
Yes, I
show.
think I can.
Yeah,
This one?
just a bit. Yeah, and then just center. Yeah, because we.
Let's see if I can center it.
Yeah, you should be able to just drag the scroll thing on the side.
Oh, scroll. Yeah, there you go.
Yeah, and then move across just to the color picture as well.
Oh, okay, fine.
Yeah. Oh, so yeah, get the color picture.
Let's do the color picture first.
Yeah.
So that's the color picture.
So we can see lots of changes on there. Does anyone want to talk about it, or shall I just say what I see?
At the moment, everybody's muted, so I don't know if anyone is trying to voice something silently, but most people are still quiet. So I'll leave it to you, Mr. Mohammed.
Okay. So
Pigmentary changes.
yeah, very
Ah.
good. Keep going. Yeah.
Some drusen.
Yeah, who's that?
Brenda.
Hi.
Hi.
Thanks for joining in. So let's scroll across to the, so there's more, isn't there? So there is pigmentation, but there's drusen as well on the color, quite widespread across the entire macula. What do you think to this OCT?
If we start with that first thing you talked about, that foveal profile is absent, isn't it? The
Yep.
dip is absent. The ganglion cell layer looks pretty okay, I believe.
Right. Shall I put everyone out of their misery?
Yes,
So
please.
again, so when the foveal dip is, you've got to decide, is it something pushing it, the central fovea up, or something caved in and dropped down? Nerve fiber is intact. Inner retina ganglion cell layers are largely in continuity. So everything's happening at the outer retina. So if we look at the outer nuclear layer, it's very interrupted. So it's no surprise this patient is having difficulty recognizing faces, because it depends on how close someone is, obviously, but the outer nuclear layer is gone in places, and that outer retinal structure is gone. So the external limiting membrane is very, very interrupted, going all across. We can see Brooks membrane. The RPE is where we can see transmission lines going through the choroid, is likely to be absent. So there's photoreceptor loss, outer photoreceptor loss, interdigitation line is gone, so there's no photoreceptor tips. If there's no photoreceptor tips, you can't have any photochemistry of vision. Ellipsoid lines disintegrated as well. We can see drusen as well. So there's a lot going on. So to use modern research terminology, this patient will have C-RORA. Is anyone familiar with this term? So that's complete RPE and outer retinal atrophy. So there's a big move towards defining dry AMD and the advanced forms because of the potential advent of therapies, because GA is just way too broad a term, and atrophic dry macular degeneration is so variable in its width, extent, speed of progression, distribution, that there's no standard accepted nomenclature. So in this patient, we know there's no surprise that the vision is compromised. Of course, their acuity is going to be good, because you can have 6/6 vision and an extinguished visual field, because that's just telling you your foveolar vision. But obviously the reading speed will be down in this case, and mesopic visual function will be down, recognizing faces, time, all that will be compromised, because they've got extensive C-RORA, or what would have been called geographic atrophy. So if we did a autofluorescence, we'd see quite widespread disturbance of the pigment epithelium, because the pigment epithelium has gone. Now, the central fovea is still preserved, and we often see geographic atrophy developing in multiple foci just skirting around the fovea, and then they, of course, expand, coalesce, merge, and then eventually migrate into the foveal center. You can see a little bit of pigment migration there as well, but the color picture showed lots of drusen, lots of pigmentary irregularity, and focal hyperpigmentation and large drusen. So again, large drusen, if it's bigger than the size of the vein at the disc, is all high-risk features for developing neovascularization. So on an AREDS classification, we'd say that's stage 3. So we'd recommend drusen. And before we open up the can of worms on photobiomodulation, we'll save that for next time. Before I preempt someone asking that. And if you go further down, I think there's some interesting stuff on the next picture. So then that next picture, yeah, that one there, has got a little oddity on it. So that little blip there,
Here.
again, we've got atrophy of the outer retinal structures. So there's this distinction between, it's a dreadful terminology. So I think it's really this C-RORA, I-RORA, see aura, eye aura. It's nonsense. It all depends on whether the pigment epithelium is intact and whether the external limiting membrane is intact and what outer retinal structures are still remaining. Because whilst conventionally we're all taught that AMD is drusen and then the secondary consequences of that, a lot of the studies going on now on early dry AMD are suggesting photoreceptor degeneration happens first before the RP changes. So it's sort of a precursor thing, maybe the time to be intervening with, well, complement inhibitors, if you believe that story. From that throwaway comment, obviously I'm not a firm believer in it. So that change there is a very characteristic appearance of something called a ghost drusen. So there's lots of different types of drusen. The drusen terminology is also terrible because you've got subretinal drusen, you've got small, intermediate, large drusen, hard drusen, soft drusen, calcific drusen. And then there's this oddity of there's basal laminar drusen, basal linear drusen, and the list goes on and on. And ghost drusen are a very specific change where once upon a time there would have been a more solid drusen, but for whatever reason, well, we know the metabolic process, macrophages get recruited, they release their lysozymes, they dissolve the contents, and then it just leaves the contour of where the druse actually was. But obviously there's photoreceptor atrophy over it because you can see transmission lines, so the pigment epithelium is gone. If you look directly into it, you probably see a little discrete focus of atrophy. So it's early GA. The expectation is this would then concentrically enlarge and then invade into. That's the sort of normal natural history of these things. It's difficult to predict unless you do an autofluorescence image, which gives us some idea of what's going on.
So I guess the question that was on my colleague's lips was, is this something we watch and monitor, or is this something we send on, given that it is still dry, given that it is
so the nice guidance says you don't hospital monitor these patients, but this patient's got stage 4 dry macular on the ARIDS classification. They've got stage 4 disease, so they've got profound disease. Now, of course, the slowest spread is towards the foveal center, so this patient's days are numbered. Now, if the complement inhibition treatment was a bit more promising than how it's materialized, then they would be a good candidate according to the clinical trials. Then you may slow down the thing, but the cost risk benefit and the actual anatomical benefit and the risks are just way too high to justify the costs. And the benefit is so modest. But we can talk about that next time, perhaps.
Yeah, amazing. I'm conscious of the fact that other people might want to leave.
Yeah, we have gone. It's coming to 9, so I'm sorry I've gone way too long.
No, I have some rather interesting Optimap pictures to show. Potentially, we'll leave it for next time. I just want to say thank you very much, everybody, for staying on for so long. It's been a pleasure to have you with us today.
Yeah.
If you have any further questions, then please do let me know. You should all have my email address, or you can obviously WhatsApp and message or get in touch with the LOC office if you need to. If there's anything specific you want, then please do get in touch as well.
Yeah, and we want to shape these sessions so they're ideally a bit more interactive, but bring your cases. It's always far more interesting when there's sort of real day-to-day cases rather than me just rabbiting on for hours and hours. So yeah, let's try and make it a bit more interactive, and then let us know, because we want to try and do a big program. So at the end of the year, you're a bit more confident with imaging interpretation, whether that's colors or OCTs, but a little bit of a widening of our sort of knowledge of day-to-day top MR diseases as well. We'll probably change some of the titles actually, because there's a little bit of overlap. So I'll get back to Bhavina with that, but we'll tailor them to what you guys want.
Yeah, amazing. There was a question about Valida light therapy. What, are you a believer?
Absolutely not. And I'll expand. Well, firstly, the clinical trial was just dreadful. There's no long-term follow-up, and which patients have ever there's never has any patient improved visual function because visual acuity. None of it makes sense. Now, maybe with there is a more I think the Euro light trial, which we'll then report in 3 years' time, may give us. But at the moment, the evidence is dreadful. The natural history doesn't make sense. The biological plausibility is not there. I'm not a believer.
No.
I'd love to be proven wrong, but I'm just not a believer.
Lovely, amazing. Okay, after that, I am going to call it a night. We are coming up to 9. Thank you so much, Mr. Mohammed, for
Right.
just keep going. You just kept going. It was amazing.
Yeah.
And very, very informative.
I'll try and
Thank
stick
you
to
very
time
much
next time.
Right. Thank you very much, my audience. I'm just going to
Thanks.
stop recording now.
And do you take do you take some feedback just so then we can tailor things? Will you do that?
Yes.
Yeah. Okay, great.
I'll be sending a feedback out
Lovely.
with the confirmation that their attendance. Yes.
Great. Thanks very much. Good night.